Okay, everyone. So thank you for coming to harm reduction webinar number 2 in our series. I'm Kelly Ramsey. I'm the Chief Medical Officer, and I'm the host for these webinars. So today we have a treat. We have Andrew Tatarski, who I included his bio in the announcements that I sent out. So I'm not going to repeat his bio. If Andrew would like to introduce himself, he is welcome to do so, but in telling you his story, I think that will cover a lot of who he is and what his work has been over the years. So we are really happy to be offering these webinars and helping people either who are already practicing harm reduction in their practices, or those who are harm reduction curious, or those that just need some sort of, how do we do this? How do we implement it in our programs? That's what these webinars are designed to do. So the next webinar in this series, I'm going to be presenting the evidence for harm reduction. So I'm going to look at specific harm reduction prevention and intervention strategies and showing you the evidence, the seminal articles behind them and the studies to give us our evidence base for those interventions. And then the webinar number 4 will be hosted by Pat Lingcourt and Joe Turner, and we'll have a variety of participants on the panel, and they will also be discussing motivational interviewing and harm reduction and how to implement it across different programs and practices. So we had 542 people on the first webinar. I'm really hoping that we get back to that number today. The numbers are still going up, so we'll give people a couple more minutes to join. But as I did with the last webinar, we will send out, if Andrew is willing to share his slides, we'll send the slides out, we'll send the recording out, and then you can share those widely. You can share them with whomever you would like to. That would be fine. And hopefully, when the series is over, then I'll post the 4 webinars with links on our website so that you have access to watch them again or share them with colleagues or friends. So we're at about 262 individuals, so I will go ahead and let Andrew get started. And thank you very much for your attention. And I intentionally muted everyone, but at any time during the presentation, please feel free to put questions or comments in the chat box, and we will get to them after Andrew finishes presenting. Thank you so much for coming.
Thank you so much, Kelly, for inviting me, and thank you all for joining this really historic webinar. I am so honored to have been invited to present my work on my application of harm reduction principles to psychotherapy and substance use treatment in this really historic webinar series. This series really reflects a historic shift that's happening in the world right now, and also more closely at home in the United States, and that OASAS is taking the lead on in making a full tilt embrace toward seeing harm reduction principles as potentially enhancing the quality of care for people that struggle with drugs across the entire continuum of care. And this is particularly exciting and enjoyable for me because I and many of my colleagues who have been doing harm reduction therapy and harm reduction treatment for many years have really been working toward this vision. That is a vision of a continuum of care that's infused by harm reduction principles that we really believe can enhance the delivery of service, can make services more relevant, more appealing, more effective at engaging people and supporting people in making positive change across that entire continuum. Right at the outset, I want to say that harm reduction is not at odds with abstinence. This is something that I want to disarm right at the beginning, that many people have thought that harm reduction is one set of interventions to reduce harm, and then abstinence is really what treatment should be all about. But actually, harm reduction in a very simple way, as I understand it, is really about attempting to offer services and interventions to people across the entire spectrum of readiness to change, stages of change, positive change goals, so that that includes the group of people for whom abstinence is a goal and a life-saving goal often. So let's think of this as an umbrella concept. that really includes the whole range of services, and that we can think about harm reduction as potentially extending the reach of traditional treatment. I wrote a paper in 2003 entitled Harm Reduction Therapy, Extending the Reach of Traditional Treatment, because also in terms of treatments, harm reduction treatment is not in conflict with abstinence-based treatment. It's really about extending, to those folks who are not pursuing abstinence, may never pursue abstinence, may not be ready to pursue abstinence, but may get there eventually. So this is really a way of thinking about opening up, adding to, enhancing, what we're doing that's working. So that's real exciting tilt, and I think it will lead to a much more effective system of engagement for people that struggle. Before I get into my material and what I have done over the course of my career is I've really been attempting to draw out the therapeutic treatment implications of the harm reduction model. And that's really what has evolved into work that I've developed that I call integrative harm reduction psychotherapy. Or we might think of it as integrative harm reduction helping, because the work that I've developed, I think, really has broad applicability to all helping relationships, including peer relationships, concerned significant others. And so this is really an offer to you to kind of hear about the work that I've been doing in my practice, in my center, the Center for Optimal Living, and really kind of think about how it might fit with, how it might enhance your work, how you might want to adapt it. So I'm really offering my work in the spirit of collaboration, conversation, and dialogue. A few words about, how did I get here? I began working with people that struggle with drugs when I was a young graduate student, and I met this wonderful, amazing, diverse group of people that I thought were really in need of better care, and that really inspired me to go into the field as an addictions counselor right out of school in the 80s. So I worked in the addictions field, and I learned the disease model abstinence-only approach to treatment, which was really the only acceptable way to work at the time, and I think it still is largely the dominant approach in the field. And I think over the course of those 80s, I worked in a number of programs. I think we actually helped a lot of people. But I began to see over time that the majority of people that were coming to our programs were not getting better. We're not sticking. We're not completing treatment. We're not stopping. Abstinence was the only measure of success according to that model. And so we were failing and our patients were failing. And over that early decade, I began to really question the model. What was wrong with the model? We were blaming people for not stopping their substance use. But in fact, it seemed to me that we as a field weren't being helpful. And that led me to question the basic assumptions, the disease concept and the abstinence requirement. Toward the end of the 80s, I had a small private practice that I started, and I started getting referrals of patients that were actively struggling with drugs, but were not interested in stopping. And I thought, well, the dominant model is not working that well. Let me experiment. Let me break the rules. Active drug users were not supposed to benefit from therapy, but they seemed motivated. They seemed like good candidates. So I thought, let me give it a shot. Lo and behold, many of those folks did incredibly well. They engaged meaningfully. They cut back their substance use. Some of them stopped. They worked on other life issues. Now I was in this kind of philosophical, theoretical quandary. The dominant approach wasn't working that well, and breaking the rules was. What to make of that? I had the good fortune of having a relationship with Dr. Alan Marlatt, who many of you may know is a giant in the addictive behaviors field. And he's one of the people that brought harm reduction over to the U.S. from Europe. I called Alan up and I said, Alan, what's going on? And he said to me, you're doing harm reduction. for me, the introduction to harm reduction was really an introduction to a whole new way of thinking about how we can set up helping relationships. And that's really how I have come to know it, and what my focus has been, to really draw out the therapeutic treatment implications of this harm reduction model. So that's what I'm going to share with you today briefly. It has really evolved into an intensive training that we've been offering. We also have applied it at our Center for Optimal Living, which is really almost like a laboratory for evolving this approach in a comprehensive treatment setting. So part of what I'll share with you draws on all of that. So let me begin by sharing some slides, and I will speak for about an hour, and then we'll have about a half hour, 20 minutes, to dialogue. So please, write down your questions, your concerns, the good, the bad, and the ugly, and we can kind of dialogue about it toward the end. Okay, so this is really the context in which I'm thinking about this work, that we're really in the midst of a scientific revolution, that we've been dominated, the field has been dominated by an old disease model introduced by Jelinek in 1960, sort of elaborated by NIDA with the brain disease idea. But I think that notion is too limiting, and we need to move toward what I call a psychobiosocial process model. That is just, in short, thinking about problematic relationships to substances as multiply meaningful and multiply determined. And I'm going to break that down, how I mean that. But that shift in paradigm, that shift in thinking, really supports a shift in practice, away from this old abstinence-only model, in which abstinence was considered the only measure of success, and really problematically, the ticket often to get into care, that is, to commit to abstinence and buy into it, and move toward what I have called an integrative harm reduction approach. So here's my plan. I'd like to share with you and us to think together about the case for harm reduction. That is, what is the clinical rationale?
Okay, I'm using my phone.
Please get yourself.
Thank you.
What are some of the realities that people who struggle with drugs bring into our offices, or that they struggle with in their lives? What are the multiple meanings of substance use? And what is this psychobiosocial process as an alternative way of thinking about what we call addiction? Then I want to define basic concepts, how I think about harm reduction as a frame, and why is it essential to increase our effectiveness in helping. What are these core principles? And then how do I apply it to psychotherapy? I've really attempted to map a model. Like, what are the core tasks that we are attempting to accomplish in a therapeutic context? And I've identified 7, which I think are really supported by the harm reduction frame. And we'll touch on some techniques that I hope, we can play with a little bit, and you can begin to take home, immediately. And we'll talk about some takeaways about this notion that harm reduction saves lives. I'd like to begin by inviting this group to think about, what are the really thorny challenges that you face in your work with people that use drugs, that struggle with drugs. What are the things that seem to be most vexing, that you've really found yourself really stumped by? And I'd like to kind of have you reflect on those things. And as I go through this presentation, let's think together about how what I'm sharing may address some of those challenges. Because I think that the history and the context in which harm reduction is really relevant and important is the history of the failure of our field, of the limitations of what we've been doing. And it's in the face of those limitations and failure that harm reduction has emerged to really offer some additional new possibilities, creative solutions. A few words about Valerie. Valerie is a patient that came to me some years back And she has her own unique story, as we all do. But what she presented was certain characteristics that I think characterize the experience of most people that struggle with drugs. She came in as a mom with two young kids and told me in the first session that she was injecting Dilaudid, powerful synthetic opioid, 4 to 5 times a day, and she had been for several years. She told me now that the only reason she came to see me was because she knew that as a harm reductionist, I would not automatically require that she stop using in order to be in treatment with me. And that's really, I think, the linchpin, the sort of the major shift toward a harm reduction approach, that we invite people to come into care while they're actively engaging in risky and problematic behavior without presupposing what the goal should be. And so Valerie proceeded to tell me that she was having a love affair with injecting Dilaudid. It was the most pleasurable experience for her. And so she couldn't imagine stopping. And yet she lived with this terror that she would be discovered as an IV drug using mom and she would risk losing her children or, creating tremendous catastrophe in her life. So the drug use was not a pretty picture. It was something that was fraught with anxiety, fear, tension, stress, worry, needing to hide her substances. And yet she was not anywhere near ready to give it up. So this was a very painful dilemma for Valerie. And that dilemma a version of that dilemma is something that I think that most people that struggle with drugs live with, right? Now, if we require stopping, then we basically often consign people to having to leave if they're nowhere near ready to do that. So, attempting to put our heads together to figure out what was this love of Dilaudid about and to help her find a way out of this dilemma became the point around which we created a therapeutic alliance. Yes, we did safety plan. I needed to be clear that she was not a clear and present danger to herself or her kids, and I was satisfied with that. Just one additional piece that we can come back to is that as we began to inquire into that love, what emerged was a history of trauma, early trauma, sexual, physical abuse, later rapes, and that trauma was living right on the other side of that, and that then became a central part of our work together. So what are these realities that I think we need to consider? Like Valerie, I think most people that struggle with drugs are not ready to take action or ready to stop. And now I want us to consider not just the folks that are identified as having substance use disorder, that is clearly problematic substance use, but let's also consider the folks that are out there who don't really have a significant substance use disorder, but are engaging in illicit drug use. And as you may know, our illicit drug supply is poisoned with fentanyl and other contaminants, and is largely responsible for this terrible overdose drug poisoning crisis that we have. So the realities are, how do we engage those folks that are like Valerie, concerned, struggling, but not yet ready to take action to stop? Another, I think, picture that we often see is that people may have different goals for different substances. They may be very interested in stopping the one that they consider problematic, but not others. And our traditional abstinence-based approach has really required total and complete abstinence. And even in settings where, which for me is really problematic, somebody may be getting an opioid substitution medication like buprenorphine and come down positive for cannabis in the urine and are discharged from buprenorphine. So that's an extreme problem. But I think this is also something that challenges us to kind of question our assumptions. And for most addictive behaviors, of course, abstinence is not realistic. Think shopping, sex, eating, screen use, and so on. So how do we engage these realities in treatment, and how do we understand them? Well, many of you, I'm sure, know about the stages of change model. I find it to be really useful, both for us to understand where these folks are in the motivational process, moving toward change, but also it's very useful to teach clients and their families, because many clients and families also say, this is so dangerous and risky. Why the heck can't I stop? Well, the stages of change model teaches us that many people are in pre-action stages for very good reasons. The pre-contemplation phase is one where somebody may be driven into treatment and may actually not have a problem. The problem may be in the relationship. Or it may be that they haven't yet connected the dots. So it's really an assessment question to sort of help people see in what ways their substance use may be problematic. When people now experience a conflict or a problem with their use, they move into contemplation. But here, there's a lot to contemplate. What is the nature of my problem? What changes do I need to make? Do I need to make any changes? What are the implications of making those changes? When I've identified a goal and I feel pretty clear that I need to make a change, we still need to move into preparation. How do I work toward that change and achieving that goal? With treatment, without treatment, with family involvement, with self-help, medication, no medication. So as you can see, the first three stages at the bottom are pre-action stages in which most people are really unclear about what change I need to make, if I need to make a change, and how might I go about that. That, again, I think is really one of the most important rationales for needing to have a treatment, interventions that can reach and engage people in pre-action stages around non-abstinence goals. And that's really what the harm reduction frame does. Let's shift to thinking together about what we call addiction. Bill Miller, Gabor Mate, William White, these are all highly respected people in the addictions field, all basically agree. So I think there is general agreement that there is something that consists of an experience of craving, compulsion, experience of losing control, and the inability to stop despite negative harming behavior. But the question is how we understand this experience. And I want to emphasize these are experiential qualities. How we understand them is going to make all the difference in how we intervene, how we treat, right? So the National Institute of Drug Abuse understands this in a very particular way. If you look at the second sentence, they understand it as a medical illness caused by repeated misuse of a substance. So they emphasize medical illness, brain disease, talking about brain changes. And I'd like us just to reflect together on, maybe the pros and cons of thinking about this complex behavioral syndrome as a brain disease. I think it's problematic in some ways. But yes, no doubt there are major biological factors. We know that genetics play a role in increasing vulnerability. We know that with chronic use, there's neuron receptor up and down regulation, neurochemical depletion, tolerance with some drugs, withdrawal with others. And so there clearly is a biological piece that becomes more and more relevant with chronic high-dose use. Does it rise to the level of disease? What do we gain from thinking about it in that way? And what might it actually cost us? How might it be problematic? Well, these are some of the ideas that really challenge the notion of, at least the notion of addiction as a chronic, permanent, progressive disease. Stanton Peele has written about, he's one of the major proponents about, the data that suggests that many people with significant substance use disorders actually are able to moderate or stop, often without treatment. And of course, many people with significant substance use disorders achieve stable moderation in treatment. We see that all the time at my center. I would say that many drug users without substance use disorders are at great risk for poison drug supply. from a poison drug supply, which I think is increasingly something we have to figure out as a society how to respond to. And then there are neuroscientists who know a lot more about this than I do, Mark Lewis and Carl Hart, two of them, who really challenge the disease concept and say that we don't really yet have the science to be able to extrapolate from those brain changes that we know about to this complex syndrome that we think of as addiction. And I would add that this brain disease idea risks kind of collapsing and avoiding complexity, that there's a lot more going on around those biological factors that we need to consider. Now, here's what I'd like us to consider as an alternative addiction paradigm. Now, what if we think about addiction as a meaningful relationship to a drug, a multiply meaningful relationship, or, like I mentioned with Valerie, a dilemma. That is that a part of one is very invested in using for complex reasons, even while another part of one very much wants to cut back or stop. And that place is a place where people are painfully caught. So let's consider from a meanings perspective that biology gets wrapped in meaning, whatever that impact is of the drug on one's brain chemistry and body. It lands in a human that is meaning making, right? It's maybe in relation to my anxiety, my depression, my self-esteem issues, my relationship struggles, that drug effect helps me in some way. And that then I turn to the substance and it may be expressing multiple meanings simultaneously, right? Meanings on top of meanings. The other thing is that some of these meanings are in my awareness. I know that when I have a drink, it helps me with my anxiety, but for others, meanings may be out of awareness. And now we need to kind of wonder about trauma and dissociation. That is, terribly overwhelming and painful experiences, either developmentally or later in life, that were dealt with by putting them out of awareness. Those feelings, those experiences that are out of awareness may actually get expression in that urge to use a drug. That was certainly the case with Valerie. The trauma, symptoms of this history of trauma really were being medicated unconsciously by her. She was managing and containing tremendous feelings of pain, suffering, rage, terror, self-hate, and shame, all under the love of Dilaudid, right? Now, the problem behavior then may be almost like a language. There's something that's getting expressed in that active user, but it may be out of awareness. So people may simply experience it as the urge to get high, right? Now, let's think about some of these complex reasons, and there may be many more. So people use drugs for fun, pleasure, liberation, self-care. Some of us find that fun, pleasure, liberation actually becomes self-medicated. It helps us with suffering. It helps us to cope. And like with Valerie, often, and we may hear more data about this in the next couple of webinars, but there is so much accumulating research that trauma is very often at the core of an addictive relationship to substances, that the myriad trauma symptoms may have one vulnerable to turning to that substance to medicate. Some of that is self-regulation difficulties. Trauma survivors feel flooded by overwhelming pain and feelings, or feel dead. And both of those conditions may have people turning to the substance. The shame and the guilt of being a trauma survivor, or even being a drug user in a society that criminalizes and stigmatizes. So all of these feelings can have people turning to substances. There is also relational need often. Think about growing up in a family in which pain, dependence, vulnerability, anger were unacceptable. So that growing up there, one had to stuff those feelings, push them out of awareness. And growing up, one learned that I could turn to a drug to care for myself rather than people. So that self-medication may also have this relational meaning that gets played out later in life. And we talked about dissociation, and these dissociated parts of the self might get expression in turning to that substance. And finally, group membership or bonding. People may feel they can connect with others when they're high or around the use of substances, when they have great difficulties with attachment. So there may be all sorts of stuff, and there may be a lot more that's going on in that impulse. That's really the idea that I want to suggest. So to the extent that this is true, that addictive relationship may express and disguise parts of the self, needs, feelings, memories, experiences that are out of awareness, that get expressed in that dissociated experience of addiction. And from this point of view, the problematic drug use, the risky behavior, and the urges to engage in that behavior might be like entry points for exploring, rediscovering, and reintegrating aspects of the self. And so to the extent that this is true, we want to invite people into our offices, into our relationships, into our treatments, while they're engaging in these behaviors, so we can create safe spaces to support people in doing this important work of self-discovery, self-exploration, and reconnection to themselves. So we ask things like, what part of you wants this? What part of you wants to use? If that urge could speak, what might it say? With Valerie, I asked her this one day, and she said why she was shocked. It's the traumatized part of me. We had never discussed trauma. That then became the central focus of our work together. Now, to the extent that these substances actually work in some way, and become coping mechanisms, they may over time become overlearned habits. Stimulus, response, reinforcement. I feel anxious, I want to drink, I feel better, and that reinforces this addictive urge. Overlearned habits may get reinforced thousands of times, and they become deeply ingrained. So while we might say this may not be a disease, it's not to say that it's easy to change. But just consider this idea that to the extent this is true, the urge to engage in that behavior we might think of it as like an axis of change. Theoretically, if we could help people stop the action around that urge, develop the capacity to sit still with it and think, then all sorts of possibilities for change open up. We can do a cost-benefit analysis. We can do that work of exploring into the urge. And then we can think about alternative ways to respond. And working in those alternatives may be a kind of a new repertoire for self-care, when we could think about that as recovery in a way, interrupting the addictive process, opening up new pathways for self-care. And the neuroscientists say, yes, these very bad habits. Well, sorry, lost my slides. Let's see if we can find them again. There we go. So those very bad habits. Can you folks see my slide? I can't see you.
Yeah, we don't see them.
See it now?
We do. Thanks.
Okay, I'm sorry. So our neuroscientist friends tell us that these very bad habits actually become laid down, wired into the brain through repetition. Think about repeating that pattern of using when anxious. And that's why, like other developmental outcomes, Mark says it's very hard to reverse. But consider interrupting those patterns and really working in a new response is really about rewiring the brain. And while a permanent brain disease can't be changed, a complicated habit pattern that is meaningful, serves a function and has become deeply wired in actually opens up possibilities of change if we can identify meaning and find new ways of expressing or caring for, and new ways of responding in a self-caring way to those parts of the self that are being expressed around the drug use. And finally, we need to think about social context. The criminalization of drugs contributes to shame, guilt, anxiety. We know that in Portugal, decriminalization has led to dramatic reductions in drug use, less overdose, more people in treatment. And Bruce Alexander is somebody that has a theory. He calls it social dislocation theory. If paradoxically, if we cut people off from sources of positive social support, they're likely to feel worse. And if where they go when they feel bad is to a drug, they're likely to use more. And so we also need to think about all of the social determinants of health. So let's consider how the biology, psychology, habit, and social context interact in a way that contributes to this vulnerability in the top right circle. There's some combination of vulnerabilities that are unique to each person that contribute to that experience of the substance being pleasurable, reinforcing. And as people use over time, there are increasing negative consequences in many areas, which may intensify the desire to use. Now you've got that addictive process in motion. But I think it helps us understand why people might continue to find the substance useful while they experience increased negative consequences. And that helps us understand that dilemma. And why any positive change in any relevant factor may change one's motivation in relationship to the drug. And so wherever somebody is motivated to begin working, that issue can be the one that we can engage people around to establish our alliance, and can become the point of contact around which we can begin a process of supporting people and making positive change, in spite of the fact that they are not yet ready to stop, or maybe in some cases even to address the substance use directly. So let's shift gears now to how does harm reduction fit into all of this? Well, Alan Marlatt, the person who introduced me to harm reduction, suggested that we might think of compassionate pragmatism as the philosophy that comes into life in harm reduction practice. Compassion drives our wish to help, reduce suffering, or promote positive change. But the pragmatic part suggests that we really need to figure out how what we're actually doing is going to be helpful to this given individual, so that we're constantly kind of questioning ourselves. How's it working? And I think that, what's happening in our world right now, in our country, around overdose, both of illicit substances.
Sorry, does anybody else's volume seem very low? I can barely hear the speaker.
Can anyone else not hear me?
I can hear you fine, Andrew. Maybe the individual should call in again.
I can hear you as well.
Yeah, mine is fine too.
Okay. So compassionate pragmatism, how's it working? I mean, it really challenges us to be constantly thinking in our one-on-one work with clients, in our agencies, in our policies, our theories, how are they working? And that's something that I think we can continually evaluate with our clients, checking in, right, to make sure that what we're doing is actually addressing that person's needs. Now, here's where I think the sort of central major tilt away from an abstinence only to a harm reduction model is any positive change. Dan Bigg of Chicago Recovery Alliance suggested, let's support any reduction in harm or positive steps without requiring that people commit to abstinence, or even more radically, without imposing our values or agendas on people. So that can really create a safe space for us to support each individual in identifying, what's true for them and what goals and approach to change best serve that individual. Then we can really meet people where they are. Are they coming in around a wish to engage in safer use, reduced use, moderation, or abstinence. As I said before, they can all fall under that harm reduction umbrella. And our really challenge as a field is to figure out creative interventions that will be relevant to people across that entire continuum. That's going to lower the threshold for engaging people in care. When we offer somebody something that's really relevant to their needs, they're going to be more motivated and willing to get on board, right? One of the things we've seen, like with Valerie, is that many people who were not motivated for traditional treatment because they were not ready to embrace an abstinence goal become very motivated when they hear there is a harm reduction alternative that can actually offer people an engagement around wherever they are, ready to begin a positive change process. So we can tailor whatever we're doing to that unique individual. And of course, meeting people without judgment and empathy, I think, are critical to this. Another central shift is away from quantum change toward gradual, small, incremental change. Maybe even baby steps, right? Maybe even showing up and beginning to talk about it can be an incredibly important step for people to take. Creating that alliance, being willing to engage in an open way. But so think about what are all of the steps that people may need to go through to discover and achieve their ideal outcomes, harm reduction outcomes. And finally, another shift here is away from disempowering people by telling them what they need to do, to empowering people by inviting them into a collaborative relationship where we actually want to invite them to come in as experts in their own experience, and involve them in a very active way in working with us to figure out how we can do something together that's actually going to be relevant and helpful to that person. So this is a whole powerful frame that we might think about that frames, whatever it is that we want to do with folks. So these are the strategies that most people know about out there that are the public health medical strategies. All of them have been highly evidence supported to save lives, help people stay safe, alive, and healthy, right? And many of you may know that in New York State, I'm proud to say we opened the first 2 safe consumption sites in the country. And these safe consumption sites, which have been around for 30 years around the world, have supervised millions of drug injections, and there has not been one fatality, which is hard for me to believe. But that gives you an idea of how powerful they can be to create safe spaces for people to come in, connect with care, and begin a process of positive change. Now, let's consider if we can link up all of the rest of our continuum of care, all of our therapeutic and treatment strategies with those harm reduction settings. People can come in wherever they're ready to begin that positive change process, and then can be linked to services that will take them to their ideal harm reduction outcome, which we think of as non-problematic use or abstinence. Now, what I'm going to talk about in the next 15 minutes is applying this to therapy, to substance use treatment, and how I do it. So these are the 3 main texts. Mine is on the left. It's filled with case studies if you're interested in how different therapists actually apply this work. Pat Denning and Jeannie Little have the book in the middle, and it's kind of like a wonderful textbook. And Alan Marlatt, Mary, and Katie did the book on the right. And this really gathers lots and lots of evidence to support the efficacy of these interventions. So how do I conceptualize integrative harm reduction psychotherapy? Well, it seems to me that if we're considering that these complicated, meaningful relationships to substances have multiple personal and relational meanings, we need to have a focus in the therapy on helping people clarify, discover, make sense of, the meaning of their relation to substances, right? So that's kind of some people call that a vertical focus on exploration of meaning. And here we can now think about making connections, between behavior and meaning, between behavior and dissociated aspects of self that are out of awareness. But I think we also need to be integrating active strategies, cognitive behavioral strategies, to promote positive behavior change. So this has been another, I think, shortfall in the field, where it's been either kind of analytic or CBT or something more active. And I think we really need to be thinking on both levels. The horizontal level, how do we help people identify what's problematic and risky, and begin to think about goal setting in a very molecular kind of way, about small goals that can actually reduce the harm and help people step in a positive direction. Mindfulness, I think, is a powerful strategy, really, which is about supporting people in bringing present moment awareness without judgment, with acceptance, to what's actually happening in this moment. And now we can bring that mindfulness to the exploration of meaning and to evaluating and goal setting around problematic behavior. And of course, that all of that happens in that harm reduction frame. So here's my map. Just a way to think about, what are the major tasks we want to accomplish in any treatment. And these tasks are not necessarily in order, although they do build on one another, but people tend to go back and forth. So when I'm sitting with a patient, sitting with a person, I'm sort of wondering, what is the task that we're working on today? But let's just quickly run through these, and then I'll have some comments, further comments about them. The first one is managing the therapeutic alliance. If we're not in alliance, if we're not in agreement with our patients, clients, participants around goals, around tasks, what we're doing together, and we don't have a good bond, then I don't think we can get anywhere. So the challenge of the treatment system is, how can we meet folks in a way that will engage them, create safety, help them feel that we're actually on their side. And I think that's been one of the major stumbling blocks with traditional abstinence-based treatment. If a person is nowhere near ready to embrace abstinence, and what we're saying is you need to buy into abstinence to get into care, there's a disconnect. So our challenge as a field is, how can we offer people an intervention, a relationship, a treatment that's really relevant to where they are. That's the basic harm reduction, the power of a harm reduction framework. And maybe we get to figure that out with each person. So alliances are negotiated. Now then, around that alliance, a therapeutic relationship, builds, which I think is inherently healing. Now let's consider that to the extent that people who struggle with drugs have had very negative relationships, often with care, police, with families, maybe with early developmental trauma that somehow has gotten played out in their use of the substance. A therapeutic relationship that will be inviting, respectful, non-judgmental, non-presumptive, and will support people in coming in with these really complex, problematic relationships with substances, offers people the possibility of a new experience of feeling worth it, which can inspire hope, which can help people begin to feel better about themselves and address some of those self-esteem issues, and more hopeful about relationships. So that's really a key part, the alliance and relationship. Both of them set the stage for this third task of enhancing self-management skills. To the extent that people have experienced trauma or for other reasons have great difficulties managing distress, managing intense feeling states, and therefore are very vulnerable to move into impulsive action, to ask them to change the behavior before we've helped them shore up those capacities to tolerate distress can be a total setup for failure. So at this stage, we can invite people in who are not yet ready to work on changing the behavior, but may be very open to developing those capacities through mindfulness, breathing techniques, cognitive self-talk. Even the positive therapeutic relationship itself can support people in developing greater capacities to self-regulate. Now we're a therapeutic team working together, and we can work on what we call assessment as treatment. That is, the whole process then of beginning to tease apart all of those meanings and functions and psychobiosocial factors that may be contributing to that complex addictive relationship. And we can also then invite people to come in and bring their ambivalence. That is, bring the part of them that wants to change and is concerned about their substance use, but also to invite the part that's invested in using for all of these complex reasons that we've been talking about. And I think most traditional treatments don't want to hear from the part that loves getting high. I would suggest that we have to hear from that part, because that's a vital part of the person that needs as much attention as the part that wants to change. And what we want to try to accomplish here is, rather than having folks in who are in a battle with themselves, we want to invite people to bring both parts and try to support kind of a constructive dialogue, right? So this part wants to use as a way to manage uncomfortable feelings. This part wants to change because of the risks associated with that. Well, now we can begin goal setting on both sides of that ambivalence. Thinking about, how might that part that wants to use find a new solution? Maybe better anxiety management techniques, other ways of understanding and addressing the vulnerabilities. And that, in fact, that goal will support increased motivation to actually cut back or stop. And now that we've got some good goals, we can set about working with people on really personalized, comprehensive plans to address both the changes with the substance use and all of those related issues that we've now been able to identify. So alliance, relationship, self-management skills, assessment, inviting ambivalence in, goal setting together, and then creating a plan. The goals and the plan, you can see, really emerge out of this whole therapeutic process. Whereas often, many of our patients tell us they walk into treatment and they start being told what their goals in treatment approach is. So I'll say a few words about each of these, and then we will be able to open it up to discussion. This is just some of the research that supports this idea about the alliance being, the strength of it being related to goals, and agreement about goals and tasks and the quality of the bond. There is some research that has shown real positive outcomes connected to therapeutic alliance and reductions in substance use. So there's a lot of research supporting this. We might think about this alliance is about creating safety for people that have experienced multiple traumas, and both developmentally and later in life, and as the result of being people that struggle with drugs. Creating safety may be one of the major initial tasks that we as clinicians, as providers, are challenged with. How do we create safety? How do we prove that we're trustworthy, right? With stigmatized trauma survivors. And here I think our engagement skills are really key to starting where the person is. Reflecting, how can I be helpful to you? Listening empathically to that person. I really want to get you. I want to work collaboratively with you to clarify what the issues are that we're struggling, just to make sure I'm getting it. Then I want to reflect back empathically how I'm hearing you, right? Just to make sure that I can check in with you and see if I'm on target. Now, when we've gone through that process and the patient says, yeah, I feel understood, now we know that we're in alliance. So these engagement skills, I think, help creating safety initially. The person can feel like they're with somebody that really wants to know them and is listening, open to who they are. And we can use these skills kind of as a foundation for the ongoing work to make sure we stay in alliance over the course of what might be very difficult, stormy work together. Now, I think that managing our own internalized stigma, we've all taken in stigmatizing images and language about people that struggle with drugs, that I think lives inside of us is what I've thought of as social countertransference, right? That can come up and kind of get in the way of our being able to really listen to this person. So I think we constantly need to be checking ourselves while we're in engagement with our people. And finally, I think that being transparent about our harm reduction stance can be a foundational part of creating safety. People will come into our offices thinking more of the same, that we're expecting them to stop, that we're thinking when they keep using that they're failures, that, we're disappointed with them or we're angry with them. That's we might think of as their treatment experience transference, right? So one way to engage that is right at the beginning to make sure, do you know that I'm a harm reductionist? Do you know what that means? That I'm meeting you with no expectations about or assumptions about your substance use, about what you should do, about what goals make sense for you. My interest is in getting to know you and supporting you and clarifying what your healthiest relationship is to substances. And I have to tell you, sometimes patients have heard that in disbelief. Nobody has ever met them like that. Sometimes they break down in tears. You mean I can be here wherever I am and be accepted? Yeah, that's the basic message that we want to send. Talked about the therapeutic relationship. I think that it can be such a powerful place to help people identify the relational dynamics and meaning of their substance use, help unpack it so that they can actually have the experience of bringing those parts of themselves that they kind of tied up with substance use into our therapeutic relationships and have the experience of being able to be safe, be whole in relation to another person. And now we can help them work on bringing those parts of themselves out into their relationships in their life. That experience of integration, I think, is another way to think about, the goal of this harm reduction therapy work. It may be one of the keys to changing different behavior. Talked about enhancing self-regulation. Well, Tansy and Crystal, there are many people that have been talking about addiction, substance misuse as related to regulation difficulties, curiosity and empathic attunement, teaching mindfulness, breathing techniques. These are all very powerful ways of supporting people in cultivating their capacities to be present with themselves in a kind of self-soothing, comforting way, and to identify distress and develop that capacity to tolerate it. So we weave mindfulness through all of the work that we do at my center. And this idea of the urge as the axis of change I was talking about, this is my favorite technique, which is urge surfing. Alan Marlatt offered that to us. Think about bringing mindful, curious, accepting awareness to that urge. That you could identify the urge before you move into action. So you can actually put a little pause around the urge. You can start breathing with that urge, with curiosity, with acceptance. And now you can develop the ability to surf it. And if the only thing you want to do is develop that capacity to surf that urge, it gives you some space to think. And like real surfing or skiing or any complex skill, if you practice urge surfing, you get better at it, right? So I often will talk with folks about just whenever you notice an urge, see if you can surf it for 5 seconds, 10 seconds, a minute. Play it, make it a game. How long can you surf that? And as you get more comfortable with it, you can then decide where do you want to go with that urge. So that's an inherently empowering technique, which, as I said, opens up all sorts of possibilities. You can also use mindfulness to kind of check out your typical pattern of use, what we call a microanalysis. How does it fit into other aspects of your life? Make those connections between the substance, the feeling, the event, the thought. And as people can really identify those patterns, it becomes possible to start intervening at many different points to interrupt the sequence and offer alternative ways of responding. Right, what do you want from it? How does it work out? What would you like to change about your use? Now you can also do what I was talking about before, right? You surf the urge, and now you can begin unwrapping it, have a dialogue with the urge, and let's explore what's living in there. And what does the urge want? What does it want to get away from? If that could speak, what would it say? Is there a part of you, a story to tell? So that's an amazing, powerful way of getting underneath the urge, opening up kind of clarification of what's living within that, so that now we can talk about new solutions, new responses, new possibilities. And I mentioned embracing ambivalence. Let's invite the ambivalence into the room. Let's get a constructive dialogue going, so that actually we can help people feel whole, integrated with their ambivalent parts, right, in relation to us, another person. And now we can talk about goal setting. We don't need to know the destination to begin the journey, right? Let's just see if we can partner with people, create good, powerful alliances to support people on their journey toward discovering, what is the greatest harm reduction goal for them, whether ultimately it's about abstinence or non-problematic use, right? But then we can help people begin goal setting in a much smaller way. What's the first step? Then what's the next step, right? So that we can hopefully come up with goals that are realistic, that can be experiments. And now we can come up with an optimal use plan, right? If you've got your goals, let's think together about how do you ideally want substances in your life in a way that would maximize the benefit, minimize the cost. What would that look like in your life? And it's a challenging technique, because we're really asking people to think through, how might it work? And for some people, total abstinence is the ideal optimal use plan. For others, it might be kind of really identifying ways in which substances are seriously problematic and kind of cutting out those use patterns, and remaining with a safer, more moderate use pattern. But it's really about helping people discover what's realistic to them, rather than having it imposed upon from the outside. So I think I'm just about ready to stop. These are the techniques that we talked about. We can talk about them some more in our discussion. We have different trainings at my center if you're interested. And I guess this is what I would like you to take away. I'd like you to consider embracing this rehumanized view of people who use drugs and struggle. Think about harm reduction, how it may be essential to helping and setting up those relationships. Think about how it can be integrated into the entire continuum of care. In your settings, can you envision bringing this harm reduction mindset into the work that you're doing? This work is really about addressing unique people and unique life circumstances, and I would invite you to become an integrated harm reduction therapist and be part of the solution. So thank you very much. I'm going to stop the share and let's talk.
Thank you so much, Andrew, for a very thoughtful presentation. So I'm going to go back. There are a few things that came up in the chat that I just want to have you address. So give me a minute. I have to scroll. So it'll take me just a moment to do that. At the beginning, you had asked people to think about challenging situations that had come up for them. So a couple people put in challenging situations for them. So I'm just going to share those. So, okay, honest and accurate reporting about the quantity and frequency of substance use.
Great. So here's where the power of the therapeutic alliance comes in, and the power of creating safety. If I feel concerned about telling you about my substance use, either I'm concerned that you will be critical, you'll be punitive, you'll be judgmental, or maybe there's actually going to be a real negative consequence. And whether that's really in you as the provider or it's in me as the person who's concerned, it seems to me that those are going to be major barriers. So if we can create alliances with people and relationships in which they actually know that they're safe, that we're on their side, I think people are more conducive to bringing in their concerns. And at our Center for Optimal Living, we have 250 patients. We don't drug test. We don't urine test folks. People basically tell us what they're doing because they're self-motivated. So again, it seems to me that the shift toward really letting people know that we're on their side, that we don't have an agenda for them. You know, the question is, what are their concerns? How might we be of help? And then people feel like they want to bring us in on what they're concerned about. Now, it may take time to really build that alliance because people who have experienced really difficult relationships around their substances may need some convincing. And in fact, I've thought it's incumbent on us as treatment providers to prove our trustworthiness, right? And so that may be part of the dance that happens. Now, just one patient that comes to mind that kind of illustrates this in an interesting way is a man I've been working with who's been in long-term recovery, 12-step recovery. He didn't come in for substances, he came in for other things. But for the first year, I would say, of the work, I often had trouble understanding him, following what he was talking about. And one day he said, you know, I've been having a sexual issue that I've been embarrassed to talk about, but I think it's time. And then suddenly he became very coherent. And what we came to understand is that it took him about a year to really feel safe enough to bring up this very vulnerable sexual concern that he had. Right? So I hope we can get there with our substance using patients before a year. And I think if the offer is, we're here to support you around your concerns around the substance, and we're here to help you even figure out what that is, people are more likely to bring us in.
Do you mind if I add something to that, Andrew?
Absolutely. I don't mind.
So I completely agree. It's really about trust, and it's really about that relationship that you have with that individual. And if they don't feel safe, respected, and trusted, they're not going to open up to you. So you just spurred a memory in me, Andrew, with your story. And I can think of something, if you've heard me give a talk before, something I always talk about is that sometimes in my clinical experience, this is my anecdotal experience over many years in practice, that often women are far more in touch with their abuse histories and their trauma histories than my male patients were. And often I would have to specifically ask about violence in order for someone to recognize that had happened to them, and they weren't necessarily identifying it as trauma. And I had two male patients who were in care with me over 5 years before they shared that they had been sexually abused, one in the military and one by female babysitters when he was a young boy. And that was 5 years in care with me. You know, and they went on to be in care with me for another 5 years until I left the practice. But that building of trust takes a really long time. And if we think about some of the short-term duration of our relationships in SUD treatment settings, it's not a surprise that you don't get there in some situations, because that can take a very, very, very long time to go. So go ahead.
What you're saying, though, is, you know, I talked about at the beginning this idea of a scientific revolution, or this paradigm shift away from simple to complex, suggests the need to really rework the way that we think about how treatment should be offered. And some years ago, Tom McClellan, who's an addictions researcher, was one of the people who said he apologized to the field because he had always promoted the idea that addiction treatment should be acute care treatment. And he realized we should rethink it to be chronic care. And maybe in the way that we're thinking about it today, is that it's not necessarily that, quote, the addictive disease is a chronic illness, but that the complexity really requires that we think about working with people in a more gradual, long-term framework than the field has really supported.
So here's another challenging situation that someone put in the chat, and this is their language, frequent aggressive outbursts when in need of opioids.
Ed Kansian, who is the author of the self-medication hypothesis, had this early on, this sort of suggestion that different substances tend to be more helpful with different emotional or psychiatric issues. He suggested that opioids are one of the best anti-aggression medications. So that's interesting you mentioned. Might it be that a person really is struggling with overwhelming aggressive impulses, anger, that they've found that opioids actually really help to kind of dampen that down? And so it might really be that an opioid medication is a medication of choice, or it might be that, if somebody is trying to get off it, that underlying rage kind of begins to emerge. So we need to be very careful about how we help people manage, any decisions about getting off. Or I don't know that this is the case, but might it be that, the way that the discussions around that person's wanting an opioid can be very enraging, right? I had a patient once who I referred to a psychiatrist, a substance using patient. And he said, tell me the drugs that you have found helpful in your life. And she said, well, a benzo and Adderall, right? And so at the end, she said, so are you going to give me a benzo and an Adderall? And he said, no, not at all. You're an addict, so why would I give you the drug that you want? She was enraged. He had just asked her what she found helpful, and then he proceeded to completely denigrate and humiliate. So, often these conversations inadvertently can leave people feeling misunderstood, not being heard, and enraged. And I'm not suggesting I know that was happening here, but these are two possibilities that occur to me.
The other thing is that individual may have been in acute opioid withdrawal, or that individual may have had overwhelming cravings. So all of those things could lead to a very, very uncomfortable and negative affective state. The next is a comment. So working in an MAT setting, specifically an OTP, we cannot discharge for marijuana, and we are keeping people because the use is decreased due to taking methadone.
That's a good thing. And I know that in the last few years, OASAS has really taken a very strong stance, and a progressive stance around not discharging people from treatment for using substances, which is one of the most bizarre things, I think, that I was taught early on. That we discharge people who are in treatment for using substances for continued use of substances. But we were taught that that's what you have to do if people don't, get sober quickly enough. That's an artifact of old, bad thinking.
And I was told that when my first job out of residency was medical director of an OTP, and I will talk about my background with harm reduction on the next webinar, but I came from a harm reduction background, and they said if someone has positive toxicology for something other than their methadone, they need to be discharged. And I was like, that makes no sense whatsoever. Obviously that person needs to be embraced, more because they are struggling. It's very interesting. Okay. The next one is just a comment. Most patients have trauma driving their use. And then the next one is a question. Can the presenter comment on how, if at all, he would modify his integrative harm reduction treatment model when working with adolescents?
Well, first thing that occurs to me is that most adolescents need harm reduction, need help. Anybody who's worked with adolescents or had an adolescent knows that if we start mandating abstinence, it's not going to go very well. That people are nowhere near ready for abstinence. So, now, let me just say also, there are limits to outpatient harm reduction therapy. That is, I mentioned, if somebody is a clear or present danger to themselves, think about the substance use in the same way we might think about suicidality. That is, that there's a point at which we recognize that the behavior is of a severity that something needs to change, or we could no longer treat this person. So there are definite limits, right? But if that adolescent is not at the point where their substance use is, severely compromising their capacity to function, I would say that a provider needs to take a harm reduction stance in order to have a hope of engaging them. And I make the same suggestions to parents, right? That it seems to me the most important ingredient in supporting young people in taking care of themselves, staying safe, making healthier choices around the substance is a positive, supportive, facilitating relationship. Which doesn't mean that parents and caregivers can't give opinions. We have very strong opinions about the potential risks of young people using substances. And I think we can educate and get educated with them. But ultimately, I think we need to come down on the side of relationship, engagement, so that they have us as caregivers and their families as people that they can talk about these complicated issues.
Next is a question regarding Valerie. How did you assess that there was no risk to the children at home?
Yeah. That question often comes up. So consider that if you were prescribed a benzo or an opioid for a condition by your doctor, you might be able to take that substance in such a way that you weren't acutely impaired when you had child care responsibilities. So I evaluated that with her. That when she was using, what was her state of intoxication? Could she use in a way that was not, when she was not going to have direct child care responsibilities? And then when she saw the kids, what was her state of mind? So I evaluated that as best I could. And I thought there was also maybe an inherent question of how did it work out? Because I want to say that her kids got through primary school and high school and are now in college doing incredibly well. Valerie and I worked on her trauma for about 18 months. And when she, at a certain point, felt sufficiently sort of better with trauma symptoms and really processing this very complex, painful set of experiences, she felt motivated, went to a detox, got off the opioids, and that was many years ago. She has never looked back. She's been on a low dose of...
Trying to muffle it. And then when I woke up, I was like...
Wait, somebody needs to mute. So, I think, as best we can, I think, and this, a version of this, I think, comes up with every parent who's a substance user. The question, actually, that has come up recently, I was asked to testify as an expert witness in a case where a crystal meth using mom was being threatened by the local community to have her kids taken away. The question was, being an active drug user, is that inevitably linked to negligent parental behavior? And what I argued there, and what I argue in all of these cases, is people who use drugs can be negligent parents and can be really good parents. And some negligent parents don't use drugs. So we have to evaluate these two things separately as best we can. In Valerie's case, I felt that she was a tremendously responsible parent who was not putting her kids at risk.
The other thing,
the case in Montana where I was brought in, the judge ultimately agreed with me and did not terminate the parental rights.
And I also think pregnant and parenting persons are put under a level of scrutiny that is unheard of. And if we think about in our lives, people who are operating not under the radar for their substance use, say from alcohol or another substance, but they never come into contact with the system, so that they're never reported. I mean, that's a whole other factor. But also, we assume that when we make a report, that there's expertise in the system that's evaluating them. And, as Andrew just said, and I've been an expert witness as well, there's not a lot of knowledge around substance use in, say, the family court system or among CPS workers. They don't really receive a lot of training. So we have to remember that, unfortunately, there's still a lot of stigma around substance use across systems, including in the systems where we may be reporting somebody. So there's a comment here. So grateful for Andrew's presentation, and I'm hopeful that what has been messaged by advocates with lived experience for years, the need for compassionate, non-judgmental care that engages in uncoercive support, will generate a revolutionary shift from punitive, stigmatizing, and dehumanizing policies and practices that blame and shame individuals and their families, and infuse a culture of hope and healing into the full continuum of care.
Thank you.
Next one is, for group therapy, would you suggest two different groups for those who are on a harm reduction pathway and those who are engaging in abstinence?
Thank you so much for that question. I love that question. We love groups. We have many, many groups at my center. We don't think that groups are where you put people to save money. Groups have value over and above individual work. Each of these modalities has, tremendous value, different kind of possibilities. First of all, it makes me think about how part of the harm reduction intent is to offer people choices, options, right? Tailoring what we offer to their unique needs. And so there are some people that really want more of a homogeneous group. And, some people, we have had abstinence-based groups at my center. There are some people who come in, they really want to be in a group with other folks that are committed to abstinence. So I think that to the extent that we can make that available, that's wonderful. But typical harm reduction groups, I think of as mixed goals groups, because most people kind of go back and forth between moderation attempts and abstinence attempts and safer using attempts, and that's part of the process of really figuring out how you ideally want and can have substances in your life. So if you've got a group where you can only be in the group when you're pursuing one of these goals, it means that you're going to kind of lose your support group. Let's say you're in an abstinence group and you want to think about attempting moderation. Does that mean you have to lose your group? So a group that is mixed goals, that really brings people together who are all committed to figuring out what their ideal goal is a group that will be able to make room for people pursuing both abstinence and moderation in the same group. So that's, I think that's, we have had people that are in long-term recovery, or 12-step recovery, they define as abstinence-based recovery, who have come into our harm reduction groups, who actually want to be in groups with people pursuing other goals, because they recognize that that's more of real life. That's what life is. So I think the more options we can have. So, we have mixed goals groups for older adults, middle adults, younger adults, for men only, for women only, for gay men. So I think the more options we can have, we have skills groups, we have the DBT group. So we can put together groups that are really tailored to the unique needs of each person, ideally.
Next is a comment. I think that it is most important for us to always be where the client is. They know when you are authentic, always. And then the next is a question. How can we integrate harm reduction practices in a residential setting?
Well, first of all, I think that each of our organizations has its own limitations. So I think there may be abstinence-based intensive outpatient programs here that are going to only accept people that are committed to abstinence. And I think that's fine if that's the program that you want to run. Similarly, if you're doing a residential program and and I'm not sure about New York State at this point, maybe we can ask Kelly, who's a representative of New York State, this question, but whether it's legal, mandated, ethical, or it's just your organization's policy, it may be that you need to require that people are committed to abstinence to be in your program. And if that's kind of what is the expectation in your program, that's fine. I think as long as you don't say, but this is the only way to do it, because that's where I think the problems come in, which is then we're shutting down the possibility of letting people know that there are alternatives. If this doesn't work for you, there are alternatives. But even within that abstinence-based setting, I think you can still adopt a harm reduction therapy stance. That is, this is an abstinence-only world, for illicit drug use. It doesn't mean that we can't still, within our settings, support people in figuring out how they want their relationships to substances to be. Maybe when they leave the program, that will even be a critically important conversation to have. If that patient recognizes, I got to be abstinent because I want to be in this program, but when I get out, I'm going to go back to using. I would say you can have a very potentially life-saving conversation with that person about, so how are you going to return to substance use safely? Or how are you thinking about that? So in that setting, we can still help people really think through, their choices. And now the more radical thing that I guess I would love this community to consider is I think that we need harm reduction residential care. That is where people are not required to commit to total abstinence. Right now we have sober living places, but you need to be sober. But, what if your patient is really struggling and can't live with their family and they need a safe place to go and they're not committed to abstinence? I think we should have some places analogous to sober living for those people to go to have a safe space. Or I do know some folks in Portugal and in France are really doing full-on residential care where people can use in the safety and the privacy of their own rooms or in a safe space, but that's a whole frontier that I think is going to be a major culture change for us as a treatment community. But I think it will save lives. Oh, and by the way, we have wet shelters right now. We have shelters for formerly unhoused people that don't require abstinence, the housing first model. And what they find is that when you invite folks into those safe spaces while they're actively using, substance use goes down, mental health goes up, people get engaged in care. It's all good, so I think we should be really thinking about that as a community.
For the sake of time, Ethan, I'm going to skip your question about mandated patients because we did 2 webinars on that pretty recently. So if you don't have those links, you can email me and I'll send you those links and the slides from those. So this is an interesting comment and question. So I just completed my associates in alcohol and substance use counseling. The college teaches that people must have a mental health diagnosis in order to access substance use treatment. What are your views on this, considering that trauma is not necessarily a mental health disorder? Just lost the second half of the question. Do you think that policy needs to change in order for people who experience trauma can access treatment? What does that look like for you?
Well, I mean, absolutely think that people who have experienced trauma and are struggling with the consequences of traumatic experiences should have their therapy or their treatment supported by in whatever ways we can support them. So, but one way around that is that every trauma survivor experiences anxiety, experiences some psychiatric symptoms or some symptoms, even if it's an adjustment reaction with mixed emotional features to the event. So I think that I would support finding a diagnosis that is reimbursable. But I certainly think that trauma, which is at the heart of these issues for so many people, deserves to be get support for treatment.
So Elisa, who wrote that question, you can also reach out to me directly because, we are the regulatory and policy agency for substance use disorder treatment programs in New York State, and you do not need a mental health diagnosis in order to receive substance use disorder treatment in New York State. So I'm not sure, what type of agency we're trying to get them services from, but you can email me and we'll follow up on that. Okay, I think we're over time. I'm just scrolling really quickly just to see if there's anything else. Somebody wrote, I love this. This makes me feel so much better. Okay, another one. It's very difficult to get people to trust you and open up honestly about substance use when they are legally mandated and we have to report substance use to that legal entity. Legal entities are not accepting of harm reduction approaches. Again, I would encourage you to watch the 2 webinars. It is not the responsibility of you as the treatment provider to take care of the court mandate. That is the court's responsibility, not yours. So that's what those 2 webinars were completely about. And so I encourage you to watch those. Reach out to me if you need those links. Okay. So we're over time, but I'm going to end with one last question. Could you expand upon the urge is the access of change notion?
So consider every behavior, physical or verbal, begins with an urge, if you can catch it. Just think about having that urge to, write that angry email, right? I mean, if you could catch that urge, you're probably going to do yourself a lot of good, right? Or the urge, to storm out of the house, or the urge, to eat that, cookie when you've decided you don't want to. So it seems to me that if we can notice our urges, catch our urges, sort of before we've moved into action, right? Then actually we're short-circuiting whatever the urge action sequence is, if that's become impulsive or addictive. So simply noticing an urge and developing your capacity to sit with it, notice the sensations in your body, notice how it moves around, notice, the thoughts associated with it, right? But with a certain curious, accepting, open awareness. And that's really the way I think about mindfulness. It's nothing more than awareness with acceptance. Like, I may not like it, but this is what's present for me right now. So if I can notice it and then breathe with it, it's like the breath is like the surfboard over the waves of that urge. And now I can hang out with it. And simply practicing urge surfing or mindful awareness of distress increases distress tolerance. We know that from DBT and all sorts of research. So the distress tolerance of sitting with an urge and not acting on it then opens up all these possibilities for thinking. Thinking becomes possible in thinking about, healthy choices. And that's really one of the central ways to think about this harm reduction work. Empowering people to be in a better position to make healthy choices as they define them. So, as, AA sometimes says, recovery is an inside job. I mean, here we're really supporting people, arming them with the skills and the support to think about their choices and determine kind of what's best, what's healthiest, what's ideal for them.
So I want to thank you, Andrew, very much for your time and your expertise. I'm just going to reiterate, if you want credits, you have to send an email. So that email goes to learningthurs@Oasis, so like Thursday, but without the DAY, at oasis.newyork.gov. And in the subject line, put harm reduction webinar number 2 credits. If you want the slides and the recording, if you work in an Oasis program, those are sent out to all Oasis programs. So whoever's your executive director or your CEO, whoever gets the emails at your organization, that's who you need to bug. If you are an Oasis staff member, you will automatically get them. If you are not in either of those categories, I don't know who attended the webinar, so I have no record. So I don't send the slides and the recording. If you want the slides and the recording, I'm happy to share them with you, but you have to send me an email. So that's kelly.ramsey@oasis.newyork.gov.
Kelly,
So
can you repeat the Learning Thursdays one? And your email keeps getting kicked back.
Sure, I'm going to put, well, then something's going wrong there because I've gotten about 100 emails during this webinar, so I can tell you my email works. So I'm putting the Learning Thursday in the chat, and I will put my email again in the chat. And we had 467 people at the peak today. So please keep coming back.
Is that learn-in without the G?
No, learning. So if I didn't put the G, that was my bad. Sorry.
And I think the first one was Kelly.Ramsey, but now you say K.Ramsey, so that's probably why.
No, I'm typing too fast.
Okay.
Hold on, I'll put them again. Okay, so here's the Learning Thursday one. This is for credits. And then if you are not in an Oasis, if you're in an Oasis program, please bug your people at your program because it'll be too many emails for me. But if you're not, then you can email me. Okay? All right. Thank you everyone for coming, and we'll see you next Thursday. I'm going to be presenting on the evidence for various strategies for overdose prevention and intervention next week. So please come back. Thanks everyone. Thanks, Andrew.
Thank you.
Thank you. Thank you. Thank you. Stop doing what you're doing. No. Yes, but no. But yeah, no. But when most is that. Yes, of course. Well, no. One is a practice. I used to have so just something but I hope I was able to speak, but I felt I needed to talk to you some things, you have a good day. Let's talk soon. All right, sweetie. Bye.